It was not desired. No one wanted to die in a hospital in the early 19th, mid-19th, even late 19th century.
Congestive heart failure and type 2 diabetes and rheumatoid arthritis, the recovery, odds for her were nil.
We see these people that are dying in their last days of life, and they're still in denial and they're still battling. And they're battling against a foe that they cannot defeat.
Another issue with healthcare providers is they are trained to save lives and to make people better and cure people. And having a patient die is often regarded as a personal failure.
Honoring Choices Medical Care is a co-production of the Twin Cities Medical Society, providing physician leadership for the health of our communities, and TPT's Minnesota Channel. Funding has been provided by these foundations and companies.
My mom was 63 when she passed. So my mom was diagnosed with pulmonary fibrosis, and it was ultimately what killed her and was on her death certificate. She also suffered from other illnesses, type 2 diabetes, congestive heart failure, and rheumatoid arthritis. She lived with us here in this house for the last 6 months of her life.
Hillary Smith Shea and her husband Jeff took charge of her care in their West St. Paul home.
I have a husband who cared for my dying mother and didn't waver, didn't blink, made her lunch every day, and took very good care of her. And I could not have done it without him. When she was sleeping, I would go and crawl into bed next to her. And I would just put my head on her shoulder because she would be, asleep, and I would just be missing my mom. And I know it's like, yeah, I'm 36 years old, I'm director of a department, and I'm supposed to be, smart and capable, but when it all comes down to it, we all kind of need our moms. So that's, that was my time to be a daughter, is I would just curl up next to her and just listen to her breathe.
The sad, tender moments Hillary had with her mother were marred by struggles with her brother over their mother's care.
It was actually philosophical in terms of how we grew up. He was really focused on the fact that my mother is a very strong, very determined woman who raised 2 children, put me through private school, all on her own. And she had basically taught us to never give up. And I agree with that. But he thought that that even meant in the last moments of your life, you don't give up. That means you make sure they pull out all the stops and try all of the treatments and do everything they can to keep her alive. Whereas I was far more concerned with quality of life. When the hospice nurse wanted to talk to us about DNRs and things like that, we had a big fight over the DNR. Because for DNR to resuscitate her, they'd actually have to push on the organ that was killing her. And how horrible to have your mom's last minutes on Earth be excruciating.
Undoubtedly, they both wanted the best for their mother. But unfortunately, like many people, Bonnie never made her wishes known.
It would have helped us tremendously had she said something. We would have had more knowledge and less rough a time had she put down that this is what I want. And every time she was having a very clear moment, she would just say, whatever you two decide, I don't want you guys to be unhappy.
Hillary and her brother muddled through, but their relationship remained strained 3 years on. Their family situation is what many medical professionals considered a worst-case scenario, but it's by no means uncommon. We are not used to talking about death and dying, and it's important to do so.
People tend to stop and not want to think about those things, on the mistaken belief that if they don't think about it or talk about it, it won't happen. Well, that's not the way it works in real life. Not making a decision is making a decision. It is making the decision to let someone else make decisions for you that may not be the decisions you want. It's a decision to let the world go on without you being a part of what's happening in that process.
But how did we get here, to this place and time where we can even have these conversations? Why don't we have any guidance or traditions to help us through these times? Probably because our parents' and grandparents' experiences with death and dying were so radically different than our own that there seems to be little to apply to our current day situations. There's been a sea change in medical care over the last few generations, and so we're having to make up the rules as we go along.
I don't find it surprising that we in American society have a tough time dealing with end-of-life decisions, because I don't think we've ever really been well equipped to deal with questions of death and dying. I think, in earlier centuries, in earlier periods where people were confronted with death and dying on a daily basis, it was a far more, I hate to say it, but a routine part of life. Through the 19th century, one of the diseases that people most typically died from, aside from accidents and injuries, were infectious diseases like cholera, which would strike cities in epidemic waves.
At that time, the sick were cared for at home and died at home.
No one wanted to die in a hospital in the early 19th, mid-19th, even late 19th century. That the people who were sick, who were taken care of in hospitals and who died in hospitals, were generally the very poor, the indigent, those without families. So, if you ended up in a hospital, that was, that belied your social standing.
One of the earliest major changes in medical care was the discovery and acceptance of the idea that germs caused many diseases. That discovery led to dramatic changes in where care was delivered.
By the early 20th century, the 1910s, 1920s, far fewer people died at home. The hospitals, administrators, and physicians recrafted hospitals as a place in which everyone should get their care, that middle-class people should go to hospitals to get their care, because in the hospital you have these elite physicians who are experts in medical care. Actually, surgeons were a huge draw for hospitals because surgery took place in hospitals where there was anesthesia, pain medicine, and operating rooms for, doing these more complex surgeries.
With surgeries and ever-increasing medical knowledge, people were living longer. Infectious diseases like polio still took their toll, but a mechanical wonder came along and changed that.
A classic medical technology that's credited with saving people from imminent death was the iron lung, and the iron lung was developed in 1929 in the early 1930s as a way to treat certain polio patients. The iron lung would mechanically breathe for the polio patient.
In the 1940s, antibiotics revolutionized medical care.
Antibiotics were the first time that physicians could really effectively treat so many of the infectious diseases that had plagued populations for centuries.
With the success of antibiotics came more new life-saving drugs.
1950s, 1960s really kind of characterized as a therapeutic revolution in medicine, because there was this massive explosion in new drugs, truly effective drugs being introduced to the market.
By this time, the home remedies and rituals of death and dying had fallen by the wayside. New technologies kept coming at a faster and faster pace.
In the 1960s, kidney dialysis was developed to treat patients with chronic kidney disease, end-stage renal disease, where the kidney damage is severe and the only way to recover is to have a kidney transplant. But of course, kidneys are in short supply. And so the question was how to keep these patients alive, while they wait for transplant. This was a technology, this was a treatment that could really sustain potentially productive members of society. That's how they talked about it.
The modern respirator, something we now take for granted, has only been around since the 1970s.
In order for patients to undergo heart and lung surgery, they needed to be artificially ventilated. And so the artificial respirator was a large part of a response to that.
And throughout the 80s and 90s and into the 2000s, better cancer treatments, more refined and targeted medicines, and a wealth of other high-tech cures have come online, all in an effort to help us live longer. So now we're here, and no wonder our parents' and grandparents' experiences with death and dying don't resonate with us. They didn't have antibiotics and dialysis and respirators to consider. If someone became sick in their time, they died, and that was that. It's not just medical technology that has grown by leaps and bounds. On an equally important parallel track, the delivery of care has evolved as well. The intensive care unit, which most of us think of as a place for high technology, didn't start out that way.
The priority of the ICU was to present an opportunity for the nurses to have intensive care, intensive surveillance of these severely ill patients. And that subsequently, a lot of those severely ill patients were on respirators or had come out of major surgery and needed a place beyond the recovery room to recover, where they could be heavily supervised and observed, and the ICU was that place. And so I think subsequently you see the association of the ICU as being synonymous with these expensive, complex machines. But initially it was really about being an innovation in nursing care.
Nursing also played a vital role in the creation of hospice care. Cicely Saunders, a British nurse turned physician, was appalled by the treatment of dying patients in hospitals of the 1940s and 50s. As a response, she developed modern hospice care.
The basis for the hospice care movement and palliative medicine from the 1960s onwards was in large part due to the need for patients and their families to really deal honestly and frankly with these important end-of-life decisions, and for physicians and other healthcare providers to take seriously the need for patients and their families to be engaged in such things, and that it was no longer acceptable just to say, oh, death and dying, you know, that just happens, we don't talk about it, it's a failure of medical care. No, this is actually a natural part of life, and so therefore it needs to be a subject of real discussion. Rather than consider patients just from the perspective of their disease and thus focus on cure and prevention, that it was important to consider the patient in their entirety, and particularly in terms of the dying patient, to get this concept of total pain. And by that, not just to look at the physical symptoms of the disease, but to also consider the emotional, spiritual, and social pain and social factors that kind of contribute to that dying experience.
By the 1970s, hospice had taken hold in the U.S., and in the late 80s, palliative care, care that improves the quality of life of ill patients, became a recognized medical discipline. Dr. Vic Sandler is the medical director for Fairview Home Care and Hospice.
I was in medical school quite a few years ago, 1972 to 1976 at the University of Minnesota. And I got very little training in medical school, almost none really on geriatric medicine or end-of-life medicine. That's something that really wasn't taught. In fact, it's up until this past year, it wasn't taught much at the University of Minnesota Medical School, unfortunately, but there's been a change this past year, I'm happy to say.
For a patient who is close to the end of their life, usually our approach is to find out what they understand and what they're most worried about and struggling with.
I think for a lot of the medical profession in the middle decades, there was a real reluctance on their part to talk about death and dying, because from their perspective, this medical model of death and dying, that they had somehow failed. So I think it is harder for that, had been harder for that older generation of physicians who were trained in that model where death was failure.
It was not part of medicine that I learned. I had to learn on my own. Fortunately, a lot of doctors have become interested, so there's a lot of focus on geriatric medicine, professional journals in geriatric medicine, and hospice and palliative medicine. Pain and symptom management are very big areas. So there's a lot of doctors interested in that. We need a lot more, but it's something that many of us had to kind of learn along the way and be self-taught.
Now I ask you to take a couple of deep breaths through your mouth like this, June.
Palliative care and hospice care intersect. What I practice in hospice is palliative medicine. And palliative medicine is defined as the branch of medicine that focuses on overall quality of life of people with serious chronic illness or terminal illness, focusing on the physical symptoms, psychological symptoms, spiritual care, and supporting those for the patient and their family, and understanding the patient is not alone, the patient is part of a system, and supporting the whole family system. With a team of healthcare professionals, the nurse, the social worker, the chaplain, our therapist, music and massage therapist, and the doctor, medical director of the hospice, along with the attending physician, on the overall care of that patient, encompassing their physical symptoms, psychological symptoms, which would include any anxiety or depression they may suffer from, as well as their spiritual care, which we call on our chaplains to assist us with. People often look at care at the end of life according to two paths. One path being very aggressive medical care done in the hospital versus a more hospice palliative approach, palliative care. We think in many cases these two types of care need to be merged. There's many people that have serious chronic illness that should have access to palliative care, and we want to bring more palliative care because they're suffering from many symptoms, physical, psychological, spiritual symptoms, and we'd like to see more palliative care approach brought to many people to improve their quality of life.
Most hospice and palliative care are delivered in the home by the family.
The hospice team acts as a guide to the care. The hospice team is there, hospice aides, and the whole hospice team of the nurse and the social worker, the spiritual care provider, the physician are there as well, but we're there intermittently. The vast bulk of care has to be provided by family members, because ultimately what we're trying to do is work collaboratively, the hospice team with the family, with the hospice patient, so we can bring the best quality of life. And to the degree we all understand each other and are working together, then we can bring that to fruition.
We had official hospice care through Health East. You have to realize that anybody who's got the heart for this has really, a gentle spirit. So even them just entering the house feels great. It's sort of comforting because they know, and you don't have to explain the whole, story to them. Even just the handling the family struggle between my brother and I, they were just stellar.
Research has shown, the medical literature on hospice care has shown that people that are in hospice for more than a week really get all the benefits of hospice care. And what those benefits are, which are very important for people to understand, is that people that come into hospice, they, number one, have a better quality of life for the days, weeks, months that they are in hospice than they would if they're pursuing aggressive care. They have a more peaceful and comfortable death. Their families do better also, and this has been studied in families that have been studied 6 months after their loved one dies, that families, when their loved one has been through hospice care, the families do better both in terms of their mental and physical health 6 months out after their loved one has died. So hospice is much more than the last hours or days of life. And on average, as I say, hospice patients, people that get palliative care that have terminal disease, they live longer. That's what the evidence shows.
Previous generations may not have been able to guide us when it comes to feeding tubes or the timing of hospice care, but that doesn't mean we're out here on our own. Cindy Dubansky works with Minnesotans of all stripes as a medical social worker and care manager. She's well versed in the details of end-of-life care.
I don't make people's decisions for them, but I help them obtain the information that they need to make decisions that they feel comfortable with. Hopefully, if I get a chance to work with them in advance to help plan end-of-life care, in which I can work with them to identify what their options are, make sure their questions get answered, help point out different issues that they need to be aware of.
Another job social workers do is interpret medical lingo.
For example, a lot of times the healthcare providers talk way over the heads of the family members. They use $5 terms when a 50-cent word would have been fine. They talk about different medications and procedures and so on, and the family may have no clue what's going on. And if I've talked with the family in advance and know something about what's going on with them and where they're at with it, or even if I haven't, I can kind of tell from the way the family's behaving, facial expressions and so on, whether they're tracking. And even if I'm not sure, I always will translate what the healthcare providers are saying into plain English.
Communication between everyone is key when dealing with healthcare. Having a conversation with family members is crucial, even if it's uncomfortable.
And it's painful to be thinking about those things and think, oh my gosh, you know, I may die someday. I don't want to think about that. But, you know, it's going to happen, whether you want to think about it or not.
The most important thing I think people and families, doctors, nurses need to know about end-of-life care is to start conversations early and to be honest.
Many people tell me that, oh, my doctor knows what I want. I'll just let him decide. There's a number of problems with that. Number one, at the time the decision needs to be made, your doctor might be on vacation. And the partner who doesn't know you may be the one providing the care, and all they have to go on is what's written in the progress notes. So that doctor may not know you. And it's also a mistake anytime to assume that other people know what you want or would want in certain situations. And that goes for not only your doctor, but assuming your family knows. A lot of people just say, oh, my kids know what I want. I don't need to discuss it with them. Your doctor doesn't really know unless you discuss it with your doctor either. Also, doctors feel a lot of pressure of legal liability issues. If nobody seems to know clearly what it is you want, it's not in a healthcare directive, you haven't really discussed it with your family, for legal reasons, you're going to get the most aggressive treatment available, most likely, unless the treatment is totally futile. Most doctors figure out when treatment's futile and will stop it at that point, but assuming isn't necessarily a successful way to get the kind of treatment you want and have your health care delivered in the way that you intend.
One of the tools for clear communication when you're unable to communicate is a health care directive. And the good news is, you don't need a medical degree to fill it out.
My common advice to people who are completing a health care directive is to focus on your values and philosophies of healthcare, philosophy of life, and so on. A lot of people say, oh, I don't know medical terminology, I don't know this and that, I don't know what's going to happen in 10 years and what kind of treatments or procedures. You don't need to know any of that. The healthcare directive is about what you want, it's about your own wishes, and looking at it from the perspective as a healthcare provider, what's helpful to us as providers is to find out what's important to you, what are your priorities in life. Some people say, as long as my heart is beating, I want to be kept alive as long as possible, using whatever tubes, machines, medications are required. The complete polar side of that, people will say, if I am not able to recognize and converse with my family, and I need total care for bathing, dressing, toileting, feeding. I'm totally dependent on others for everything. Just let me die naturally. No tubes, no machines, don't resuscitate me. Just let me move on. And there's a lot of things in between. So matching values and philosophies with whatever the healthcare situation is at the time is helpful, because then we can look at, okay, if we do this treatment or this procedure, this is the likely outcome, but gee, that's not consistent with what they say they want. It's, you know, it probably will keep her alive longer, but may not make her any more cognitively aware, you know, so they can match that up. Nobody knows what treatments or health is going to be like in 10 years. So the values and philosophy is a way to kind of get around that issue.
With all of our welcome advances in medical care, both technological and in care delivery, we are at a time when we've never lived longer and healthier lives. So it seems unfair to have to think about dying, to actually need to say the words, to express our wishes about what to do when we're dying feels painful. But it can help to think of it as a kind of insurance. We have health insurance, car insurance. This is like values insurance.
People don't like to think about getting sick, being in a car crash, let alone dying. But the reality is, you're very likely to get sick at some point between now and the end of your life. You're also very likely to have some kind of injury or car crash or accident of some type. Those things happen. And we all know that we're all going to die, whether you like to think about it or not. So my number one advice is to be realistic and realize those things happen.
And because they happen, ensuring our values is a way to take care of ourselves and those around us. It's a gift to our loved ones to spare them from the kind of conflict Hillary's family faced.
Honoring Choices Medical Care is a co-production of the Twin Cities Medical Society, providing physician leadership for the health of our communities, and TPT's Minnesota Channel. Funding has been provided by these foundations and companies.